Let's talk about amputations. An amputation is the removal of a body part, either surgically or because of trauma. In the US today, the number one reason we see amputations is vascular disease, especially diabetes. Trauma comes in second. And I want you to remember, this is not just a surgical event, it's a life-changing event for patients. About 2 million people in this country live with limb loss, and that number is expected to climb to over 3.5 million in the next couple decades. Certain populations, like African Americans, are at higher risk of amputation because of the disproportionate burden of diabetes and vascular disease. So when you care for someone with an amputation, you're not just addressing a wound, you're addressing mobility, identity, independence, and quality of life. The surgeon always tries to save as much of the limb as possible. Why? Because the more joint preservation you have, especially knees and elbows, the easier it is to rehab and fit a prosthesis. Toe or partial foot amputations. These can affect gait and balance. Syme amputation. That's an ankle disarticulation, often done for severe foot trauma. Below knee amputation, BKA. Preferred over above knee because keeping the knee joint saves a ton of energy with walking. Above knee amputation, AKA. Done when tissue viability is poor, but it makes rehab harder. Hip disarticulation. Very rare, but usually leaves patients wheelchair dependent. Upper limb amputations. Aim is always to preserve as much functional length as possible. Sometimes, if there's severe infection or gangrene, the surgeon may do a staged amputation. First, a guillotine amputation to remove dead tissue and control infection, then come back later for definitive closure. Complications. Let's be clear on the risks. Patients may face hemorrhage, big vessels are cut, infection, especially with traumatic or contaminated wounds, skin breakdown, prosthesis can rub, phantom limb pain reported by up to 80% of patients, contractures from positioning and muscle imbalance. Comorbidities like diabetes, vascular disease, or depression make recovery even more complicated. PASH medical management. The immediate goals are heal the wound, shape the residual limb for a prosthesis, control edema and pain, prevent contractures. Dressings can be rigid, removable rigid, or soft elastic bandages. The idea is to control swelling, protect the incision, and shape the limb. Some patients even get immediate post-op prostheses so they can begin moving early. Rehabilitation. Rehab is never just physical. It's physical, emotional, and social. The team is big. Physician, nurse, PT, OT, prosthetist, social worker, psychologist, and of course the patient and family. Support groups, peer visits, even veteran-specific programs. All of this helps patients accept the new reality, learn coping strategies, and use prosthetic devices effectively. Nursing process assessment. Always assess neurovascular status of both limbs. Look for infection, gangrene, drainage. Evaluate nutrition, protein, vitamins, calories. Assess comorbidities like diabetes, anemia, cardiac or respiratory issues. Don't forget psychological assessment. Grief, anxiety, or denial are common. Nursing diagnoses may include acute pain, impaired skin integrity, disturbed body image, grief, impaired self-care, impaired mobility, potential complications, hemorrhage, infection, skin breakdown. Nursing interventions and applications. 1. Relieving pain. Assess and treat both incisional pain and phantom limb pain. Support the extremity gently. Movement of bone fragments and muscle spasm hurt. Opioids for surgical pain, adjuncts like anticonvulsants, antidepressants, or beta blockers for phantom limb pain. Non-drug therapies, mirror therapy, massage, guided imagery, TENS. Encourage patients to report phantom pain. Don't dismiss it. It's real, and acknowledging it helps coping. Promoting wound healing. Daily inspection of incision and residual limb. Measure limb circumference every 8 to 12 hours to track swelling. Neurovascular checks, pulses, sensation, movement, skin temperature. Maintain aseptic dressing changes. If the compression bandage comes off, reapply immediately to control edema and preserve limb shape. Teach the patient how to bandage and care for the residual limb once healed. 3. Enhancing body image and resolving grief. Encourage patients to look at, touch, and care for the limb early. Be present during those first mirror experiences. Allow expression of grief, anger, fear. Normalize it. Involve family, counselors, and support groups. Help the patient shift focus from loss to rehabilitation goals. 4. Promoting independent self-care. Teach dressing, bathing, toileting techniques with or without prosthesis. Use adaptive equipment for upper limb amputations. Encourage slow, consistent practice with supervision. Don't rush them. Build confidence by reinforcing progress, even small steps. 5. Achieving physical mobility. Positioning is key. Elevate limb for first 24 hours, but after that, avoid prolonged elevation or flexion to prevent contractures. No pillows under the BKA stump. Risk of hip flexion contracture. Encourage prone positioning 20 to 30 minutes several times a day. Keep legs close together to prevent abduction deformity. Early ROM and strengthening. Hips, knees, arms, trunk. Overbed trapeze, push-ups, weights for upper body strength. Teach safe transfer techniques, gait training with PT, and use of parallel bars or crutches. Watch for fatigue. Pace activity to build endurance gradually. 6. Preparing for prosthesis. Bandaging or shrinker socks to shape the limb into a conical form. Massage once healed to toughen tissue and mobilize scar. Progressive weight-bearing exercises as prescribed. Teach skin inspection and hygiene to prevent breakdown. Work closely with prosthetist for fitting and adjustments. 7. Managing complications. Keep a tourniquet at the bedside post-op in case of massive hemorrhage. Monitor dressing, drainage, vitals for bleeding. Watch for signs of infection, redness, drainage, fever, leukocytosis. Prevent skin breakdown with careful hygiene, residual limb socks, and regular inspection. Educate patient to report skin irritation or redness promptly. Home, community, and transitional care. Teach patient and family how to care for the limb and prosthesis. Assess the home environment, remove hazards, ensure accessibility. Arrange PT, OT, and home health follow-up. Encourage participation in peer support groups. Reinforce health promotion, nutrition, exercise, screening. Remind caregivers to look after their own health and seek respite if needed. Evaluation, what success looks like by discharge and follow-up. We expect the patient to report manageable or absent pain, including phantom limb pain. Demonstrate wound healing and proper residual limb care. Show acceptance of body image changes and coping strategies. Regain independence in ADLs with or without prosthesis. Achieve safe mobility and prosthetic use where possible. Remain free from complications like hemorrhage, infection, and skin breakdown. Takeaway for nurses. Amputation care is not just surgical. It's pain management, wound care, body image, mobility, education, and psychosocial support, every bit as important as the operation itself. Your role is early recognition, ongoing support, and empowering the patient toward independence.